So the Impact AF study was structured as an unblinded because there was no sham CDSS tool that the primary care physicians were going to involve. It was intention to treat. It was a cluster randomized trial. So what that allowed us to do was it allowed us to be sensitive to changes that would be happening over the course of the duration of the study. The unit of randomization were primary care physicians or the practices within which the primary care physicians worked. So once we had a primary care physician randomized, any others who wanted to participate within that practice all went to the same arm. What happened then was those physicians would be enrolling patients. So whereas the unit of randomization were the physicians or their practices, the unit of analysis were the patients. In addition, what we did was we did purposeful randomization to include a mixture of urban and rural practices to gauge whether the CDSS might have had a differential effect depending on the environment in which the physicians were working. What we found was that when we looked at time to first events, there were no differences that we were able to establish either in terms of the composite endpoint or in terms of the secondary endpoint, which was looking separately at atrial fibrillation related emergency department visits or cardiovascular hospitalization. We also looked at stroke, ischemic, and other, didn't see any difference there. The primary safety endpoint was the ISTH definition for a major bleed. The only modification we made was to include patients who had required emergent use of a parenteral reversal agent. And what we found there was there was no difference whatsoever. In fact, perhaps importantly, the rate of major bleeds or life-threatening bleeds was only about 1.5 to 2% during that one-year course, which should be reassuring to any physicians that have concerns about the use of antithrombotic therapy in their atrial fibrillation patients. And this is including older patients because the mean age was 72 years in our particular study. One of the interesting things, though, and this is only hypothesis generating, we were not powered to look at it, was when we actually took a look at events, we found that notwithstanding that there were a similar number of patients who had an event at least during the study, the number of patients who had recurrent events were much greater in the patients managed by usual care versus those in the computer decision support system arm. In fact, there was a 30% reduction in events in the patients whose physicians had access to the CDSS. Again, hypothesis generating, we can't draw any conclusions from that, but the trial went for a one-year duration, and it sort of begs the question, had we had more patients, had we had a longer duration of follow-up, could we have found a statistically significant difference? Now, in terms of the power of the study, we actually had enrolled 25% of all primary care physicians in the province of Nova Scotia, and we had enrolled upwards of 12% of all the patients in the province with atrial fibrillation. So we were somewhat limited in terms of the sample sizes that we could have accrued, but perhaps if we had followed these patients for a longer duration, we might have seen a benefit. So I think what Impact AF does, it provides a bit of a cautionary tale. There are a lot of these software applications that are being developed right now to provide support for physicians and for patients with regards to the management of their medical condition. And many of these are not actually being tested according to the stringent methods of testing as we will evaluate a new drug or a new intervention, such as a new catheter, a new stent, a new ablation procedure. And to the extent that these sorts of softwares can considerably impact patient outcome as well as system resources use and therefore costs, it seems to me that there needs to be an increasing requirement that these tools should be assessed. Because as I think we showed in Impact AF, just because you have something that might be conceptually interesting and might intuitively impact patient outcomes, we didn't see that significance. Whether we should have been power specific to look at events is something that is debatable. But at least on a go-forward basis, what I would challenge developers is that they prove that their tool is effective.